Well, firstly, thank you very much to 3D MedNet for giving me this wonderful opportunity to do this video interview. My background is that I'm a transplant surgeon in training and a registrar here at Guy's and St Thomas's Hospital, which is one of the largest centres that does kidney and pancreas transplants in the UK, and also one of the largest centres that does pediatric transplants, kidney transplants. And I'm also a research fellow under Professor Nizam Mahmood here at Guy's and at King's College London on a Royal College of Surgeons research fellowship. There are two aspects to my research. One is looking at ex vivo normothermic perfusion of organs, which is essentially a new technique, perfusing organs outside the human body to try and improve them and try and look at various ways in which we can therapeutically modulate them. But the aspect that I'm going to talk about today is 3D printing, which we're trying to use to overcome and address some of the problems in difficult anatomical surgery. So that's my background at the moment. And how I became involved in 3D printing? Well, I went to a lecture about a year ago, organised by the Department of Medical Physics at St Thomas's on 3D printing. And after the lecture, the idea occurred to me, perhaps, of trying to use this technology for difficult paediatric transplants that we do, and try and integrate some of that technology into the operative field. So coincidentally, the Department of Physics was organising a competition for new ideas, which I entered, and we won that competition, and hence that collaboration was set up. And I'm delighted to say we work with a fantastic, dedicated team. So this includes myself and my mentors, who are Mr. Nikos Kasaris and Professor Nizam Mahmood for the 3D printing work. We have a radiologist called Dr. Narayan Karanithi, who is our radiologist on the team. And of course we work very closely with my two colleagues, Mr. Nick Byrne, who's a clinical scientist in the Department of Medical Physics and Imaging and Biomedical Engineering at King's, and Dr. Andy Coleman, who's the head of non-ionizing radiation physics. So it's a fantastic collaboration and a very dedicated team to try and generate this new technology for use in complex pediatric transplantation. So the Royal Society of Medicine is one of the UK's oldest societies in medicine. It goes back to about 1805, and it's a very prestigious society. It's got honorary fellows in the past such as Darwin and Pasteur and Paget from Paget's disease. And essentially it's a society that provides postgraduate medical education and also promotes exchange of ideas in science and the practice of medicine. And the section of surgery of the Royal Society of Medicine holds their annual surgical meeting, where they award the Norman Tanner Prize to trainee surgeons for original ideas or innovation and application to surgery. So you have to apply for that meeting, and it's a competitive process, and if you're selected you have to present your research to your peers, and you get asked questions about your research. So I presented some work that we did on our outcomes of 350 children that we've transplanted over the last 10 years or so, and comparing children who are very small, that is less than 20 kilograms, compared to children that's more than 20 kilograms, and looking at their outcomes and graft survival after kidney transplantation. And then I also spoke about some of the work we're doing with 3D printing as a translational model into operative surgery to help us look at more complex children and how we can help with their transplants as well. So the medal was awarded for that work, which we're delighted about. The other prize, the Cutler's Prize, well, that goes back to the worshipful company of Cutlers, actually, which is one of the most ancient City of London livery companies, back I think almost to 1400s, and they used to produce swords and knives and surgical instruments, and they worked quite closely with the Royal College of Surgeons of England, and they instituted the Cutler's Prize and the Clark Medal, again for applications of a surgical technology or the design of a new instrument for innovation into surgery. and so we applied for that this year, and again we were very fortunate to get that award too. One of the challenges that we face in paediatric transplantation is fitting an adult-sized kidney into a very small abdomen, a very small child, and by small I mean less than 20 kilograms. Not only is this technically challenging, but also the new kidney, adult kidney, essentially requires a higher blood pressure, if you like, and acts as a shunt, requiring it to drive its physiology. So there's also, a physiological perioperative management issue with transplanting adult-sized kidneys into very small babies. Sometimes these children also, despite the size discrepancy between the organ and the abdomen, also have congenital malformations or abnormalities with their blood vessels that we join the new kidney onto, essentially. So this could either mean that the blood vessels are missing, they are either twisted, they are the anatomical arrangement is slightly abnormal, and this can complicate an already complicated operation, as it were. So what we currently do is we rely on the interpretation of a CT or an MRI scan of the relevant anatomy, and we discuss this in a multidisciplinary team with surgeons, radiologists, nephrologists, ITU staff, and we have a plan of how to perform or approach that particular case. And what we're hoping by this new technology is that it offers an additional layer of planning and possible safety to what we already have and already know. It allows us to have a hands-on simulated approach to a case, which we can discuss amongst a group of surgeons to give us the combined knowledge, if you like, of all those individuals in planning a particularly difficult case. So I've got some models here which I can show you. So this is the model abdomen, if you like, of a 10 kilogram child who was born essentially with kidney failure due to an abnormal heart rhythm. She had also had previous extensive abdominal surgery because the blood supply to her bowel was compromised at the time. And as you can see there, it's quite a small abdomen. And this is the kidney from her father that we took out through keyhole laparoscopic surgery. And you can see the size discrepancy just there. And we then use this to help us plan the approach to the case. So here's the liver, you can see, here's the pelvis, and here's the lateral abdominal walls, and here you can see the blood vessels, the aorta here and the inferior vena cava just here. And so the model essentially allows us to think about the best approach of the kidney's blood vessels to the baby's blood vessels. It allows us to think about the lie of the kidney within the abdomen. It gives us some indication of space, and the best approach, as I say, to the recipient's anatomy, and looking for that window, if you like, in which to perform our suturing. In addition, you can see the native kidneys just here of the baby. They're quite small, the size of a small walnut, and the model gave our team some idea perhaps of whether we needed to take out the native kidney here. You can see that just there, in order to create space to put the new kidney in. But we figured from looking at the model that we perhaps didn't have to do that. But of course, that's a decision that we also take at the time of the operation. So one of the limitations of this model, well, firstly, you can see here that the elasticity of the tissues doesn't exactly represent human elastic tissue properties, and that's something that we're trying to work on at the moment. So in fact, in real life, the skin and the muscles are slightly more elastic than what it is in the model. However, the printer has the ability to print in different physical properties. So the pelvis of the child is printed in a very hard material, and the liver, which is quite soft in real life, is printed in a very soft material. So that's something that's quite useful in the model itself. This is another child that we transplanted. So this is again adult kidney going into a very small child, again 10 to 12 kilograms. Abnormal kidneys here. You can see this child has an abnormality coming from the aorta. It's an aneurysm essentially of what we call the inferior mesenteric artery. And again, the models help us think about our approach of the blood vessels of the donor kidney onto the aorta and vena cava of the child, but also helps us think about perhaps what we might do with this slight abnormality at the time of surgery. So we decided to transect this aneurysm off and ligate it just at its base there, where you can see the plasticine just there that we practiced on. How does this process work? Well, the printing process essentially involves the interpretation of CT and MR data, and then the printer essentially molds a liquid polymer resin, if you like. It cures it under UV light for about 12 hours to produce these morphologically specific models. So it takes about 10 to 12 hours or so. We're hoping to use this technique in future complex cases to further evaluate its full potential. It's a very promising start with the cases that we've done so far. This type of technology is not for every case. As I said, it's for the most complex cases where perhaps the implantation operation is uncertain with respect to feasibility. We feel that it does allow surgeons to discuss possibly alternative strategies in a multidisciplinary setting with the models, in operations where they might expect some challenges. It allows preoperative reflection on some of the anatomical issues, and of course it's got a great value, we feel, in consenting for families. Well, that's a very good question. We wanted to look at ways in which you can make the consent process more informed for the families that are undergoing this type of transplant. As you can imagine, it's very stressful for a family to have their child on the operating table in one hospital, the children's hospital, and then their partner, be it mum or dad, in Guy's hospital, having their kidney removed through keyhole surgery, sometimes at the same time. Occasionally we have to operate on the child first to determine feasibility of the actual procedure before we can give the go-ahead to removing the donor kidney. But often it happens at the same time. So that's quite a stressful time for the family, as you can imagine, especially for the parent who has to look after both at the same time. So we wanted to make the process of consenting more informed. So when I show these models to the families, their initial reaction is, wow, I mean, this is, is that my kidney, or is that the baby's abdomen? And immediately the whole perception of the operation and the procedure becomes clearer when you can see and hold and touch and feel a three-dimensional reconstruction, if you like, of their anatomy. And they can readily relate to that because it's specific to them. So it's not a generic model from a factory or something like that. It's generic to them. So they can readily appreciate perhaps some of the problems that we may encounter and some of the technical issues. And that's important when the operation that we're doing is high risk, and when perhaps some of those risks are not entirely quantifiable at times. So we believe it's a very useful consenting tool. And the children are delighted to see also their models, because it's their anatomy, isn't it? Again, that helps the child to be slightly more involved, if you like, in the whole process as well, to sort of grasp that concept. So of course we need to do more cases to evaluate its full potential, but this is a very promising start. We're certainly hoping to employ this technology in routine clinical practice. We perhaps feel that after evaluation of more cases, that might become a reality for complex children who perhaps, as I mentioned before, the feasibility is uncertain of them having an implantation. Also, we feel that this technology might be of use to smaller centres performing complex pediatric transplantation as well. So it offers an additional training opportunity for junior surgeons as well. And essentially you're offering an archive of collected models which are disease and morphologically specific for a particular case. And that I feel is an unrivaled training opportunity for the future generation of pediatric transplant surgeons. So there are lots of value with these models, and we're certainly hoping that it will be employed in clinical practice in the future. But we have some way to go before that. So I think one of the limitations obviously is finance. Money seems to be a problem everywhere really. The whole process really involves a dedicated, integrated multidisciplinary team. As I said, we work quite closely with medical physics, and I think that's critical as well to overcoming any barriers or any problems. But money is definitely one of the financial limitations that we're all faced with in any type of innovation really, or research. The next big step really is bioprinting of organs, and there has been some success with various tissues that have been transplanted, that have been bioprinted, such as bone or liver and cartilage. The kidney is a very difficult organ, I'm sorry to say, because it's quite a complex arrangement and function of different cell types. And one of the problems with the kidney is trying to vascularize it as well, trying to determine if we can generate the blood vessels required to actually vascularize the organ itself. So that's one of the limitations. In addition, bioprinting really involves additional complexities, such as differentiation and choice of growth factors, choice of cells, choice of materials, and how we're going to integrate that entire infrastructure, that bioinfrastructure, into generating a new organ. But certainly there are various laboratories around the world addressing that problem. It's exciting, and that really is the next big step in 3D printing. What we're doing here as surgeons and as clinicians is to try and perhaps de-risk some of those complexities in the actual operation itself, and we're hoping to look at bioprinting in our unit very soon as well.